Welcome from Maryland joining us. San Francisco. We're from True Evolution. Welcome from Berkeley, Riverside, lots of California over here. Boston. We had a great call out to Boston last week during the session. All right, I'll leave you space to keep introducing yourself over in chat. And I just want to go through some logistics before we get started today. Couple things, if you would like subtitles for the call today, you can also find that just on the bottom of your page. If you look for closed captioning and you'll just turn them on there, you may have to click subtitles to get that going. And just a sense of pacing for today, our time together is about 90 minutes. We're going to use about an hour of that for conversation with our esteemed panelists who are joining us. And then we'll have about 30 minutes or so for audience Q&A. We may take some questions even sooner, depending on how that's going. If you would like to ask a question, we want to encourage you to use Zoom's Q&A function. Again, you can find that over on the bottom of your screen if you're joining by desktop, and it'll just help us keep things organized a little bit more. And if time allows, we would love to invite those asking questions to come off mute to do so. So if you do ask a question, just be prepared for that. And today's session will be recorded. So just want you to know that any of your comments or questions may be part of that recording as well. We're going to share the recording with registrants within the next couple of days following this session. And then we'll also edit it down afterwards and include it on our podcast, which is called Mistrust, that you can find on any podcast player. And that should be showing up in the next few weeks. And lastly, we like to keep this conversation going after this live session ends. It's a really important conversation. So feel free to share your thoughts and questions on Twitter and LinkedIn with the hashtag #EndMistrust. So with logistics out of the way, let's get to it. I'm Lisa Lombard. My pronouns are she and her, and I'd like to acknowledge that I'm joining you from the traditional, ancestral, and unceded territory of the Coast Salish peoples, the Squamish, the Tsleil-Waututh, and the Musqueam nations. I'm one of the co-founders of Spotlight Trust, a consultancy and training provider on a mission to make the world better by developing more trusted organizations, leaders, and communities. And as we dive into the second part of our live conversation on understanding and addressing medical mistrust, I want to take a moment to thank the panelists from Conversation 1, which took place last week and explored medical mistrust from past to present. So I want to thank Dr. Oni Blackstock, Dr. Cynthia Gomez, and Sean Demmons. They were outstanding and gifted us a thought-provoking conversation that we're continuing here together today. And I also want to thank Shannon Weber for such a warm and insightful co-moderation. And Shannon is here with us today in chat. I saw her over there, and Laura Lazar as well. And Laura's been instrumental in the planning of these conversations. So thank you, panelists. Thank you, Shannon. Thank you, Laura. And here on video, you might have noticed her already. I'm delighted to welcome back Dr. Oni Blackstock, who will be my fellow moderator today. It's wonderful to have you join us again, Dr. Blackstock.
So much, Lisa. It's wonderful to be back again. Hi, everyone. I'm Dr. Oni Blackstock. My pronouns are she, her, hers. I'm speaking with you today from Manhattan, also known as Manhattan, unceded land of the Lenape people. It's really, again, a pleasure to be back to co-moderate, which a panel that I'm sure is going to be incredibly dynamic. I'm a primary care and HIV doc, also researcher and intersectional equity advocate. I've done studies looking at medical mistrust in the context of HIV, as also provider trainings on medical mistrust to providers. And so now I'm really excited to have our panelists each introduce themselves. We can start with Ace Robinson.
Hi, thank you, Oni. My name is Ace Robinson. I serve as the Director of Strategic Partnerships and Impact, and also the Director of the Center to End the Epidemics at NMAC, formerly known as the National Minority AIDS Council. My real focus is how we are going to address the disparate health outcomes for individuals who identify as racial and ethnic minorities, gender minorities, people who are street involved or homeless, people who use substances, or really we're talking about the people that the world has treated poorly. And then, like, going back to my background, I never thought at this point in my career that it was going to be so salient that like I began my career in vaccine development. I used to be a basic researcher, a lab rat, all those things that we used to, what we call ourselves. And like we spend a lot of our time talking about virology, how we're going to move things forward. But then that side of what they call implementation science, how are we going to take what is created and make sure that it's given out to the community in an equitable manner, which means everything from education to access to sustained care and messaging. So I'm so glad we're having this conversation today. Thank you for inviting me.
Great. Next, Jim, why don't you introduce yourself?
Good afternoon, everyone. Thank you so much for having me. My name is Jim Pickett. I've been working in the field of HIV for the last 20 years or so. Prior to that, I did several years in community press. People maybe remember zines way back when, before there was really internets and blogs. And we did a weekly zine and actually made a living at it for a few years. Also got into a ton of trouble. Moved into health and health policy, public health, did a number of social marketing campaigns. And I've been at AIDS Foundation Chicago as the Senior Director of Prevention Advocacy. I've now been there 16 years. And my portfolio really focuses on research advocacy for new modalities in development and implementation advocacy for those modalities once they come out the other end and have to actually be introduced and made available and accessible to populations. And I think one of the key things we've learned from rolling out PrEP, and we will soon have new versions of PrEP, but oral PrEP, we have seen that medical mistrust plays a very big role in creating challenges for us and for our communities to accept this modality. So that and COVID-19, we couldn't be having this conversation at a better time, and I really look forward to getting it going. Thanks.
Great, thank you. Cis?
Muy buenas tardes a todos. Me llamo Cecilia Teresa, but everybody knows me as Cis. I use she, her pronouns, ellas pronouns, or any pronoun said with respect. I'm a nurse and the director of education at Howard Brown Health here in Chicago. I've been here for almost 10 years now. What I do is provide cultural competency, or what we call now cultural humility, critical consciousness training to multidisciplinary healthcare professionals. And the very short version of that is we try to teach existing healthcare providers how to be nice to queer people. That's the short version. And I'm interested in this discussion as a person who brings multiple perspectives. I'm an older person. I identify as a dyke, I'm a Latina, I'm a nurse educator, and I have clearly seen our communities have reason not to trust medical systems across those identities in my family. So I was really excited to listen into the conversation last time or last week. I am wearing my Fight Like a Girl socks and I'm ready for an exciting conversation. Thanks for having me.
Great, thank you, Cis. Gabe, would you introduce yourself?
Yes. So firstly, thank you for inviting me to the conversation. I'm really excited to participate, and even more excited that I get to see my brothers Jim and Ace and be in the dialogue with them. My name is Gabriel Maldonado. I use he, him, and his pronouns. I am the founder and CEO of True Evolution. We are a community health and social justice organization based in Riverside, California, serving Riverside and San Bernardino. We do HIV care and prevention services. We have a mental health clinic. We do emergency housing, and now we're very excited to be housing developers. So this is a new frontier for us, and so we're very excited to contribute to adding, new units to the very big shortage in available affordable housing units. I think my interest in this conversation really stems from the role that community-based organizations should, could, and can continue to play in bridging this divide with medical mistrust. I've always been a big believer in sort of the neighborhood community model. And I'm also a big believer in addressing social determinants of health and creating these sort of comprehensive wraparound spaces for our community. And how do we integrate ourselves into the core of the people who may have a historical distrust for us. And so, really as a community-based org, I'm a big advocate for other CBOs around the country and and sort of how can we play a better role in this conversation, and what are some learning lessons as well. So, but thank you.
Great, thank you to our panelists for those introductions, and thank you again to the audience members for joining this important and I think much needed timely conversation. So the time to remedy, I think, the failures of policy and public health and healthcare and research is long overdue. I think the COVID-19 pandemic, we can agree, has further highlighted these failures. We also know that research has shown that racism and other isms and phobias impact the way that healthcare providers interact with patients and have a negative effect on the health of people of color, of queer people. And so centering the lived experiences of Black, of Latinx, of Indigenous and other people of color, as well as queer and trans folks, is really, really necessary as we course correct toward rebuilding and repairing the relationships that we have with our patients, with our clients, with the communities that we serve. So in conversation one, some of you may have joined us then, we discussed the roots of medical mistrust, both historic as well as contemporary. And we were left with the following call to action by Sean Demons, who is one of the panelists. And Sean said, it has to be people like you and everybody listening saying, hey, we want to change something. You are the change. You have to step up. You have to risk something, because when you're talking about the lives of people who are most impacted, the Black, Indigenous, and Brown people, poor people, it's going to take those people in power to say no. So if Black lives really matter, and all that chanting, walking down the street really mattered, we have to put that into policy. We have to put that into action, and we have to hold the people that are currently holding the power accountable for change. So thank you to Sean for that very powerful quote and call to action. And so today we will be discussing the various multifaceted approaches that are needed to remedy, and the actions from small to big, to individual, to collective and institutional, that you can take to help shape a practical path forward towards transforming the healthcare system into one that earns and deserves patients, clients, and communities' trust, and provides high quality, culturally literate and responsive and empathic care to everyone. So we're going to begin the panel with the first question for the panelists. This is kind of a big question, but one I think that you're all very ready to answer. And so that's looking at, as we think about addressing medical mistrust, about creating change, what are interventions or shifts at both the provider level and institutional level that you would propose to build trust and move towards transforming the healthcare system's relationship with patients from one that's patriarchal to one that's a partnership? And this can sort of extend beyond the healthcare system to public health more broadly.
Great, great question, Oni. Thank you for that. I know that you and I have had these conversations in the past, but I think one thing that is very important and salient is to ensure that leadership reflects the communities that they're serving. And when I say leadership, I'm not talking about senior management. I'm not even really talking about the EDs and the CEOs. You have to say, if the fish rots from the head, like growth also comes from the head. So when we're looking at the board of directors, when we're looking at the individuals who are the funders who are putting all these pieces together, how are they being held accountable? And then also holding the people who report to them indirectly accountable to providing these culturally responsive services that are desperately needed in our communities, right? So I think the short version of what could probably be a dissertation of an entire conversation is like, how are we going to turn that mirror around? Like taking a message from our colleague, Dr. David Malbranch, how are you going to turn that mirror around on the healthcare providing community and say, you have absolutely failed these particular populations for as long as you've been in existence. So number one, should you still be getting money? Number two, are you doing a hard, realistic look at why you have failed these individuals? And then if you are, then what does that change look like? And change does not mean, and I'll repeat this over and over again, having hiring a Black person into the position of the director of diversity, equity, and inclusion. That is not the same thing as making sure that your senior leadership is diverse. To hire someone to do the Black job or the Latinx job or the Alaska Indian American Native job. So being very realistic that, like, we have to have a space forward to be responsive to communities, because I don't think you don't need a health and diversity a DEI director if you already have that level of diversity in your organization and through your clinic. It only exists for organizations that have totally failed, absolutely failed the communities that they're trying to serve.
Thank you, Ace. Any of the other panelists want to add to what Ace spoke about this turning this mirror to the healthcare provider community, to really ask why have they failed and what would change really look like? Panelists have any other thoughts or questions?
I've heard Ace speak to this point many times, and I have yet to see the change you're asking for. So I agree 100%. Before I want to respond to this, because I do have an idea about how this can be improved. Is after last week's conversation, I just wanted to make an observation. It was excellent, thought-provoking, really powerful. And I'm firmly convinced that in order to address medical mistrust fully, that we have to have a multifaceted approach, but we also have to be approachable. And when I listen to these panels, I love the energy. I can hear the education. I can hear those student loans as we talk to each other. And I want to make sure that a large part of the language that we use can sometimes be exclusive. And that is something that, if we were to broadcast this conversation for the people that really, I think, could benefit from hearing some of this, I think sometimes we're definitely preaching to the choir when we're having these conversations. But one of the things I want to be very intentional about as an educator is to make sure that the information that we get out to community, because I think many of the solutions to this problem has to do with tapping into communities. Super important. The perspective that I was thinking about was, I talked to a couple of our providers kind of to prepare for talking today. And one of my colleagues shared with me that their process really includes focusing on a patient-centered framework that includes being aware and mindful of harm reduction, trauma-informed care, providing low threshold care. They start all of their interactions with new patients by trying to meet them where they are, getting consent, asking permission before asking any questions, suggesting any treatment, medication, any referral. The challenge with that is that the vast majority of curricula in healthcare, it's a little better in medicine. It's still really awful in nursing. That's, of course, where my heart is. And I am fully ashamed of the fact that it's not part of curricula across the country. Those are the immediate changes that I can see happening that could change things right away. That if we can teach people while they're still in school that these are the most important things to do, to think in this patient-centered way during these formative years, that's what's important. They don't directly address racism. Sometimes they address bias. All of the things that I think are those barriers aren't addressed. And so, in addition to what you're saying, Ace, and putting the leadership to task and holding them accountable, we need to do the same thing for education systems across the disciplines.
Great, thank you, Steve. Yes, this emphasis on what can healthcare professional schools do to also play a role in training competent providers. Gabe and Jim, do either one of you add?
Yeah, I think one of the things that I had mentioned to Lisa in our pre-interview is that a lot of times, and this is from the perspective of a direct service provider, is that many times, while medical distrust is certainly tied to historical traumas, generational distrust, not just with medicine and the healthcare system, but with institutions and the state broadly. But I think setting that aside, in today's culture, many times distrust just begins with an irritation. You know, it starts off where I came into the clinic and you called me out of my gender or used a name that wasn't my preferred, even though I've told you twice. Or that it took me 2.5 hours to be able to complete my paperwork when you told me to get prep only takes 10 minutes. But you didn't tell me that I wasn't going to understand my paperwork. And we start off with that. That's where often it begins. And then sometimes a microaggression happens or a discriminatory moment occurs, or maybe it's just miscommunication. Maybe it's just miscommunication. And so my organization, what we try to do is when we want to address medical distrust is we look at the practical day-to-day experiences of our clients. And so I just wrote down like a couple of bullet points that I know things that we do, which I could say are like practical interventions. I'm looking at our question. One is that ease of process. So, you know, we try to make it that clients spend no more than a total of 5 minutes completing paperwork. So if that means investment in digitizing all of your paperwork and creating a master template that auto fills in the paperwork, then you as an institution, we do that to try and ease up the process, whether it's how many people they work with or how many calls they need to get linked to care. But we try to make the ease of the process as best as possible. Second one is literacy. Being able to understand the material, both in your language, but also for your reading level. Your environment, you know, a lot of us, our places look like institutions, and that just kind of compounds the trauma around medical distress. So like put a couch somewhere, put a cute photo, you know, have one of the ball kids do a photo shoot dropping out and just put that on your wall. Like that'll just make a huge difference. And then familiar faces, and ACE and CEASE both also reference that as making sure that our institutions look like the people that we serve, but also come from a shared experience. So those are just a few of mine.
Great, thank you, Gabe. Jim?
I'll bring in the cleanup here. And it's hard to add much to all of this brilliance, but I am gonna call out myself as a white cis guy. And I think white people have a lot of work to do in this space. Our systems are white supremacist, they're patriarchal, they're capitalized, they're dehumanizing. And as I kind of mentioned, I did mention in the chat last week, I think we need to burn it all down. Now, burning it down does sound a little harsh, and maybe we all aren't gonna light matches today, but I think there's ways we can dismantle, if not burn it down. We need to build in time from an organizational institutional level to have relationships in community. And these aren't things you can just develop when a grant is due or when there's a crisis. Like if we're having crisis around COVID-19 and we have a lot of people suggesting they're going to have trust issues with a vaccine coming, which makes sense, right? Hopefully all of us have been having relationships in community that go back years. So when we have challenging conversations about public health needs, individual needs, what the vaccines do and don't do, we can build on that trust. And if we haven't been having those relationships, the time to start is really now, and you never end. This isn't term limited. It goes on and on and on forever. Building those relationships so we can have, so that trust develops, and trust develops over time. And, you know, I think one of the things in the system that really personally, I mean, the system itself, the whole healthcare system is a mess, but the time limited nature of everything, our interactions are short and they feel brutal. Even for those of us who are like experienced advocates and know how to ask for things and demand for what we need, we still have 10 minutes. And it's very hard to get at people's personal background, their culture, who they are in 10 minutes when you also have to go through the list of symptoms and signs and prescribe something. So we gotta stop, we gotta figure out how to stop doing that. We gotta give people the time they need. And I think, I don't remember who brought it up, but it made me think of health equity. And I'll end on this. You know, a lot of us are really working towards health equity, which is a step beyond equality. right? So equality is making sure everyone gets a bike, but everyone gets the same bike. Health equity is everyone gets a bike that fits them, that's tailored to them, that fits their body, fits their needs, fits how they move, fits how they may have challenges moving. And we can't figure that out. We can't have a system that's based on health equity and reaching people and meeting people where they're at and engaging them as individuals if we have these tiny little slots of time that have dollar signs attached to them.
Thank you. Thank you to all our panelists. That was like an array of different strategies and approaches. And I think Jim spoke to the way, and I think as well, the system is set up really to breed mistrust, and that it can vary. Any trust that's built can just very quickly be eroded. Just as a follow-up question, and I'm just wondering, in the work that you've done, one strategy for overcoming mistrust is to validate a person's experience or a community's experience. And I'm just wondering, in terms of your interactions with patients or clients or community members, what real life examples do you have of validating mistrust as part of implementing a preventive measure, perhaps PrEP or some other preventive strategy?
I'm gonna jump in because it's hot in my mind, and I might, with my elder mind, I might forget after the other smarties say something. So I'll just give one example. Prior to PrEP being approved, and sort of after we knew it worked, and we knew people were using PrEP off-label for actually years before 2012. But my organization launched a blog called My PrEP Experience, where we encourage people to tell their stories, either accessing PrEP, taking PrEP, how they did it, what worked, what didn't. And it wasn't anything like groundbreaking or revolutionary, but what was nice about it is it was honest, and people got to share their honest opinions. If, I'm a PrEP advocate, I wanna get PrEP to people, I want PrEP accessible to people. But we didn't stop that. We didn't stop people from saying, you know what, PrEP really sucked. I didn't like it. It didn't work for me. I was sick all the time, or I hated taking the pill every day, or I had a really bad interaction with my provider, or whatever their story was. We accepted that story and we published that story. We amplified that story. And I think that went some ways. I don't think that fixes everything, but I think sharing stories that are honest and transparent. Not everyone's going to have the 5-minute uptake on PrEP and have it all be easy. Like being upfront, you may have signs and symptoms. The bureaucracy is a freaking nightmare. If we paper that over, then why would anyone trust us once they get into the system and they realize there's a lot of hoops to jump? So I think providing venues for people to tell their story unfiltered and unedited is one small way we can get at that.
Jim, can I just invite you for 1 second? Because I think PrEP is going to probably come up a few times as an example in this conversation. Can you just share a little bit about what PrEP is so we can just level everyone in this conversation get on the same level and with our
Thank
audience
you.
as well?
Yeah, I'm kind of in my HIV bubble, so sorry about that. So PrEP is a medication that prevents HIV, and it's connected to a program of services that help you be successful. So currently PrEP is an oral tablet, either a tablet called Truvada or a tablet called Descovy, and there's actually now a generic version of Truvada. And typically these are prescribed once a day, one pill once a day, although there are different dosing regimens for different kinds of people. Soon we will have other kinds of modalities, so long-acting injectable drugs that last in your body longer than a pill a day does. So it's really generically, it's a medication that prevents HIV, and then all the surrounding services. So PrEP is not just a prescription, it's a program. It includes regular HIV and STI testing. It includes support for adherence. It includes medical monitoring to make sure that that drug is not doing you harm and that your body is staying safe and healthy. And also I look at it as an entry point to link people to all kinds of other things. And I'll end on that. No one on the planet has their one and only need being HIV prevention. And for many folks who have a need for HIV prevention, there's a list that precedes it that is quite long. So I think for any PrEP program, if they're really legitimately working in community and helping community, they're also linking and helping provide services and help people get all the things they need beyond this medication and the program that goes with it.
So I think that's a great example of exactly what we're talking about when we're talking about how are you going to find solutions to address medical mistrust. So like Jim was saying, this HIV prevention pill, which would have been a godsend in the early 80s when we were just learning about HIV's existence. If you look at who's utilizing it today, 3/4 of people who have prescriptions for PrEP are white, cisgendered, gay men. And then when you look at the data that tells you the rate of who's most impacted by scope and scale, like white cisgender gay men don't come up in the, I think they're number 5, if I'm correct. So like we were looking at Black queer people, Latinx queer people, Black cisgender heterosexual women, American Indian, Alaska Native individuals. So how are we going to make sure that, number one, the community knows that it exists and that it's for them? Give big kudos to Jim's group and other folks in Chicago who developed a PrEP campaign that actually looked like the people who were acquiring HIV at unacceptable rates. So people who had different body types, so people who were predominantly Black African American. It was a really great idea of like, how are you going to engage people? How are you going to make sure that they know that something's for them? And having something for them, if you look at early ads about PrEP or who was actually knowing about PrEP, it was always like relatively skinny white guys. And one thing that is really important is like, who is the messenger? So as many of you know, Dr. Blackstock has an identical twin. And just yesterday or the day before, Dr. Uche Blackstock put on Twitter that she was really moved by the fact that there was a patient who was talking to a patient of a different clinician who was saying that they saw Dr. Blackstock on TV talking about like the prevention and treatment options for COVID-19. And because they saw a Black doctor on TV talking about it, then it became real that this was true. Like Tony Fauci, who's all over the news now for things that have nothing to do with healthcare, more politics. But one thing that he's very clear about, he's all like, I need other people to step forward and get the attention to talk about HIV and other illnesses. He wasn't talking about COVID at the time, but he knew that he was a white man in his late 70s, a cisgender heterosexual white man in his late 70s, talking about the needs of predominantly queer, trans people of color. So that's when you're like, the messenger matters, because if the Black version of Dr. Fauci goes forward, then everyone's going to listen in the Black community. If someone who is Hispanic Latinx is listening to someone who's also Hispanic Latinx who comes from a similar background to them, you're going to pay more attention. So I like that's what we're talking about. It's like, how are we going to get around medical mistrust and all of the, like, how it's been seeded and seated inside of our communities? How are we going to undo that? And I think PrEP is just a great example of an absolute failure in the HIV community to reach the people who were coming into the clinics with new HIV diagnoses.
Great, thank you, Ace and Jim. Gabe and Cease, do you want to add to that? Any experiences that you've had around validating mistrust that any of the clients or patients you've engaged with have experienced?
I just want to pivot a little bit to research. I know that that's a huge area of mistrust. But because recently I've had the opportunity to work on a few community-based participatory research projects that, thank God for public health people, because the level of commitment to engaging community is, it's just critical to what we're talking about. When a research project starts and ends with talking with the community, like it's not research to for, it's research with the community, then that makes all the difference. So because the process typically is, we have this great idea that we think is going to help you, something from on high, as opposed to, hey, we see this issue and we'd like you to help us figure out what is going to be the best way to help it, and get your opinion to start, and how we should do that, and who we should talk to, and how do we engage community stakeholders, and then at the end, after it's all done, how do we get the information back to you and tell you, have that community reach back and talk back and explain, hey, this is what you've contributed to, this is what is so important. And there are plenty of those studies. They're small. They are absolutely, they start at the place where they're validating mistrust. They're saying that from the beginning, hey, we get it. You have had horrible experiences here, but we're going to turn that on its head and we're going to talk to you about it first, as opposed to coming in the patriarchal way that it's always been done. And so I know that I know there are ways to do research properly. And as far as I'm concerned, that is the only way to do it, because it really does. It's a participation with, as opposed to something that's coming from outside. That's meant to, aggrandize someone in academia. It's a completely different approach.
I was just going to add again, from a direct service provider perspective, from just a very practical implementation perspective, many times, our clients come to us monthly with something that we did, you know what I mean? And it's just the way it is, you go to love your community, and we did this child, and then she done offended her, and she called her that, and she was transphobic, but it was a trans girl who was transphobic, but you didn't know she was a trans girl. She made you mad, so we got to remedy that. That happens, right? It's just very day to day in the life of a community-based organization. But one of the things that I really love about being a CEO, that I just love about running this institution, is that if there's something that is just, it may seem so far out of reach for the client to be able to see that happen, whether they want your hours of operation to be different, or you didn't have something written in Spanish properly, but you have it in English everywhere. And, just simple things, right? If we can actually do them, I think there's one way to give clients a voice, give them a space, make an advisory board. But if none of those things actually result in something looking different for them, then that just furthers the distrust that they have that their voice matters. And clients are also not naive or dumb. They are firmly aware that institutions placate them. They are very cognizant of you being condescending. It's called shade, and it's called a read. And they know that. It's just different intellectual vocabulary on it. But they know when you're being shady, that you're not really coming through on the things that they say that they need to look different. So I would just really encourage, from a practical perspective, that when our clients do voice themselves, when they do, express that there is a concern, that we actually integrate in your weekly meetings. You integrate, how are we going to tackle client issues today? How do we allocate money for a director of customer relations or a director of customer experience? And then they're empowered to actually make institutional changes on behalf of the needs of the clients. So I would just encourage that from a practical perspective.
I guess just circling back from what you just said, I'm personally interested in the people who chose you as the CEO. What did that board of directors, were they diverse? Was it a group of white people? The people who chose you to lead this, and you obviously transformed healthcare in Riverside. What did that look like from a top-down perspective?
Well, I did have the very privileged benefit of being a founder. So I got to organize my board in the beginning. We got to put the right in together. So we did that. And, I would say no now today, as far as the top-down leadership is concerned, you're absolutely right. How do I not clock my own tea, but just give a very honest story right now. I have had multiple experiences where I have personally seen that not having the highest levels of your leadership be not only reflective of the community that you're serving, but that they understand the lived experience of not only what it means to your population, but understanding the lived experience of CBOs, of frontline workers, of community outreach teams. You need to understand that world. And even if you're not in nonprofit leadership, you need to have that understanding. So yes, from leadership perspective, certainly my board is amazing. I am in love with my board. It's the best relationship ever. And it's the only reason why I can do the things I do. But I know that they are also intentional about making sure that our membership is not only reflective of the population, but that the membership also understands where we come from and who we are. And if you don't come from that philosophical jive, then you're not going to make it past round one.
I love the responses coming in so far. I think when we talk about a topic like medical mistrust, it can feel really overwhelming. And everything that I'm hearing you saying is breaking it down to practical actions that can be taken with a little bit of intention and a little bit of thoughtfulness. And I think the audience is feeling that too. I'm seeing a lot of yes, yes, excellent, a lot of encouragement from there. And we've got some wonderful questions that are coming into Q&A right now. And I just want to call in that Rick Kitagawa, co-founder Spotlight Trust, he's helping us kind of navigate the Q&A right now. So if you have those questions, get them into Q&A and we can bring them to our wonderful panelists over here. And I want to toss out the next question, or toss over the next question to you, because this is a topic that's already come up and I want us to call it in a little bit more explicitly here. And I'd love to ask, and anyone who wants to address this, what role does white supremacy play in the reinforcement of medical mistrust? And how might acknowledging this play a part in changing how things are done so that the healthcare system can earn the trust of all of us, not just a select few?
Did you say what part? And was that ironic? So I was just like, I think it's, I mean, if it's not 100%, it's definitely 99 point something. And you know, I'll leave it there. But I really think we need to, like, it's not up to those of us other than you and Jem to fix racism. Like, people of color didn't create it. We're not benefiting from it. Systemic oppression is really systemic uplifting of particular communities. So I'll I'd love to hear like what Jem had to say, like how the white community at large, and as you can speak on behalf of all the white community of humanity, is able to do this work that has to be done, because like, it doesn't matter how many degrees, how many accolades, how much programming we're going to do. I don't think we're ever going to, well, we might one day reach the benefits, because just giving one example of someone who remained nameless, she sued one of those firms that picks CEOs and senior leadership, because like somehow she got a hold of who they had placed, and like saw that all these positions that she applied for had been like, every single one of them, she had been like passed over by a white person who had less academic, professional, vocational skill set than her. So I think we have to address those things that, like Gabriel was saying, like a great board is doing great things, but then some boards will, like I think when we were talking about the least impacted, like Lisa's demographic, white cisgendered, I don't know if you're heterosexual, but like white cisgendered women are the least impacted by HIV on the planet. And then like you look at organizations that will place someone from that demographic as the head of their organization. It's repetitive in the HIV field. It might be in other fields too, but it's so repetitive in the HIV field. And we know that systemic oppression is just shown by who they choose as their leaders.
Well, that was a nice setup for me, Ace. And yes, I will now speak for all white people. Happy to do it. I think, well, first of all, you were right about 90. I would say even maybe more than 99.9. I mean, white supremacy, it's the alpha and the omega, the A to Z, beginning to no end, right? I mean, it has just been our reality for over 400 years. It is deeply baked in. It is baked in so much that, yes, many, many, many white people don't even realize it. They have no idea that they have privilege. They get mad and they argue back when you talk about what white privilege is and that they have it regardless of any other circumstances in their life. So I think one key thing that white people can do is to push back on this. We are sometimes, Lisa and I are likely, I don't know, Lisa, maybe not, but sometimes we're in rooms, right, where they're all white, or there's precious little diversity. We need to be calling that out. We need to be acknowledging that. We need to be recognizing that and saying, how do we do better? How do we make sure we have different viewpoints in this room? This really isn't acceptable that we're sitting in a room filled with white people. We also have to invite, be proactive and not wait for the room. Bring people along with us. Make sure that before we show up in that room, that people with different experiences, different race, ethnicity, gender, religion, age, etc., are brought in. But going back to when we're in a room where we're maybe filled with white people and we hear some bullshit, we need to call it out. We need to clock people in those situations. Call it in, call it out, but we need to call it because it's not acceptable. Silence is complicity. Silence is criminal as far as I'm concerned. Silence is how we got the Holocaust. A lot of people were silent. A lot of people have been silent the last 4 years. And we can't do that. And if we are really here in the HIV space or in any public health space, we are serving the community. We are serving a beautiful, rich, diverse, luscious community. We cannot allow racism at any juncture, and we can't allow any, we have to call that out and stop it. And frankly, that means that we're not always gonna be popular. In fact, we're gonna be really unpopular. People are going to not want to be around us. Some of our white brethren may not feel like they want to hear another harangue from you, but really that's what we need to do. Because, you know, taking the hits from other white people who are annoyed with you is really nothing compared to the daily onslaught of injustice that people of color, Black people, brown people, Indigenous people face every single day, and that so many of us are oblivious to. So I think it's using our space, it's using our privilege, it's using the platforms that we have to not allow this nonsense, to call it, to say we have to do better. And I'll stop there because I could really go on a continuous rant, but we need to hear from some other people right now.
I did want to hop in. I think what both of you have said is that acknowledging, yeah, I agree, it's 100%, 99.9. Ace, you're being very generous today. I don't know why that happened. But I agree 100% is really where it's at. And I think about, I have such a unique perspective. I'm a very light-skinned Mexican. I don't have an accent at all. That's why I introduce myself in Spanish every time I'm in a meeting or I'm starting an education, a training of any sort, because I start by modeling the behavior that I want people to do. I want people to immediately be thinking, "Oh, wait, why did this person introduce themselves in Spanish?" And it immediately gives me the opportunity then to start talking about, so when I bring up implicit bias, I've already started that conversation. When I want to talk about racism or white supremacy in the existing hierarchies of healthcare that are just structurally perpetuate medical mistrust. So when I bring it up, it's not a surprise. I'm modeling what I think is important for them to know. And I also don't hesitate to tell them my own personal journey with race. Like, I was brought up as a white kid. My parents intentionally did that. And I didn't learn about really who I was until much later in my life. And so people need to know that they can grow and they can learn and they can change their behavior over time. And I don't like to let people off the hook. I think they need to be on the hook, but they also need to know that there's a way for them to move forward. And so, yes, you're right, Ace. It's not the responsibility of people of color to teach other white people how to do this, but it's sort of my job. So I do kind of have to teach people how to do this, and in particular in the healthcare space, because as far as I'm concerned, that's where the most harm happens. And so that's really the perspective, I think, for me, that is just so critical, is I have to be willing to put myself out there and say, yeah, this is the way it is. This is what you're doing, and it's wrong. We have to do it different.
So we're actually getting some questions in. Oh, Gabe, were you going to say something?
Sure. I mean, I think the only thing that I was gonna, bring into the conversation is that it's going to be really important that in the progress of us trying to root out, white supremacy and all of the many tentacles that it comes within. And it's not just the obvious manifestations of racism, as Jim had said previously. It's patriarchy, it's privilege, it's economic privilege, it's it's a whole host of other assertions of dominance and superiority. But I think one of the things that we have to understand is that white supremacy and racism over the many years have transformed themselves, just as the liberal movement and the progressive ideas and these, liberal ideas that we have transformed as well. And I'm always very cautious of, people who get caught up in their own grandeur of being liberal and progressive. And I think a lot of times institutions and systems, as Ace put in the beginning of his comments, we're so quick to pat ourselves on the back for the diversity inclusion department. And we get caught up in our own ideas that, we are the not racist white person. We are the non-homophobic hetero, and I think we privilege ourselves in that a lot of times. And I think it's very important for all people in leadership, particularly Black, brown, white, is that you have a sounding board of people who will call you out on your shit. Like, that will always call you out, that will always let you know that you off base. I never thought that, well, I did think, and I just didn't think it was going to come that quickly, that I am not youth anymore. And no one in the institution sees me as youth in any way. So those days of me speaking on what young people need, I have to digress from that. That is not my place anymore. And I think we all have to do that in leadership, is to check our own privilege, check our own temperature, our own pulse. Where are we as it relates to our connections with our people? And we should do that, not just calling other folks in on those conversations, but calling in ourselves as well.
Yeah, I think, and Gabe, to your last point about checking leadership, checking their own privilege, we have a question from the audience around knowing that the culture of organizations is set from the top down, and that many top jobs are not held by Black, Latinx, Indigenous folks or trans folks. How do we encourage those in positions of power to see that power? How do we get them to live out the values that they are speaking? So I don't know if any of the panelists have any thoughts on that, because I think Jim spoke to the point about the importance of stepping back and calling out behaviors when we see it, but then how do we, when we see folks in leadership who may not be reflective of the communities they serve, how can we ask folks to step to the side or cede power?
I think we have to just do that, right? We have to ask those folks in those positions to step aside. If they're not hearing that in their own head, like, I'm no longer, like, I think it's really pertinent, you're no longer youth, Gabe. Neither am I, by the way. And that you can't speak to that. And if you're going to be a leader and lead in a community that is diverse, we need to have that representation. And so I think it's about asking people and pointing out the value and reminding the people who are in those positions there are other roles they can play. I think one of the things, I am by far I am not some major magical role model. But one of the most valuable things I've learned in my years doing this work is stepping aside, letting bringing in folks who represent the population I'm working with, basically young Black queer people, putting them in charge, stepping back, stepping away. I'll tell you, it's painful, because I still feel like, I don't know, maybe I'm still hip in there some way, maybe I still have something to offer. But what I have to offer is letting them have the space and do what they do and just support that. Just follow. Sometimes the best leaders follow, and you don't have to be at the head of an organization as a white person to make a difference and to be really helpful and powerful in your community.
I was just going to say that last month, True Evolution celebrated its 13-year anniversary. And I've been having those kind of holiday nostalgia reflections about life and people and work and career and what does it mean. And I will tell you that when we started this organization, there wasn't really anything. in our area and in our region, and certainly nothing that was queer, and nothing that we saw that was HIV focused, certainly not that. And I'll tell to all people of color, or all folks who feel as though they come from marginalized communities in which they are not at the forefronts of leadership, create your own. Baby, create your own. And not everyone is entrepreneurial. And when I say create your own, that doesn't always mean that you are the CEO and the founder. It just means that the opportunity for that is for the community at large to be able to create its own and to develop and funnel its own. And as someone who built an organization in a more rural community, I will tell you that even in the most rural, homophobic, racist, historically, conservative regions in California, it's possible. And so create. That would be my recommendation, is to create.
Does anyone else want to jump in on that audience question? All right, I'm going to go to the next question. We're going to make more space for audience questions coming in. We've got even more of them now. So we're just going through to sort out in order to ask them and seeing where we might be able to clump some of these questions together, because there's some similar themes that are coming up. But in the meantime, I want to ask this one next question here, because I think this might cover some of the things that have been coming up in chat as well. And that's knowing this shouldn't fall on patients. And we talked about that a little bit last week, especially those patients coming from traditionally marginalized communities. But for patients or clients, what are practical individual level actions that they can take to empower themselves in our current system?
So the first piece, when you are mistreated by your clinician or by a clinic in general, so there's certain commissions out there where you can report poor behavior, and there is, and really it's about empowering individuals to know if they quote unquote snitch on their doctor, then that they're not going to have some sort of backlash. And if they do receive backlash, that clinician will probably lose, probably get officially censured or lose their position or be or lose their board certification. So there are ways to go forward and say that something is unacceptable. And really, you can do it individually, you can do it anonymously. You want to be sure that you have that power to say that something that doesn't pass the sniff test, it didn't feel right. And remember, all those clinicians are working for you. It's not the other way around, and that's really hard when you come from a background where you're supposed to do what the doctor says, and if they tell you to do this, you're supposed to do that. Your parents might have told you that when you were 4, and you still think that when you do get in front of a doctor that you have to cow down to however you're being treated or what they're ever saying. But the data tells us that doctors make a lot of mistakes, sometimes intentionally, and that you have to be like, this doesn't feel right and I was mistreated. Report them, just like you would report the person at Walmart or Target who treats you bad. You just don't let it go, and because you just that assumption that we all have, and a lot of our community, especially my community, that when you complain and when you raise attention to mistreatment, that you're really helping the person who comes after you. Your situation will be what it is, but the people who come after you are going to have a better experience, either with that clinician or within that clinic or within that system.
I agree, Ace. That's a really important first step. The thing that always pops into my mind is when I went back to school, I got something that's called a clinical nurse leader certificate. I had to take a test. Anyway, the focus of that role is to be a patient advocate. It is, if it's in community health, it can be focused on education, like what I do. If it's in an inpatient setting, it's focused on helping anybody who's having a longer stay really understand what's happening on the day-to-day in that situation. But the problem is that this is typically not a budgeted position in a lot of systems. It can be like, if I use Howard Brown as an example, we have patient navigators who talk to people about, unless it's paired with a specific issue. So we have people that talk to people about HIV medication and adherence, insurance benefits. We also have a navigation team helping trans people who are looking for gender affirming surgery and how to get through that whole process and system. It is just so lacking. Somebody who comes in and needs help just understanding the medical jargon is really going to be challenged. If you can't absorb the information, it becomes a really stressful situation. But we also have another piece that we use, that has been really helpful, is that we have embedded behavioral health consultants in our community healthcare setting. So if somebody's really having a tough time and they're not understanding it, they're becoming anxious, we have that immediate, hey, can we have somebody here that can come in and talk to you? Can they come and talk to you right now? That whole one-stop shop thing is amazing. But it's so lacking. Nurses have been put in the position of being advocates and they're not trained to be advocates. So that's not kosher either. And it's just not a piece of the puzzle that needs to, piece of the system, as far as I'm concerned, that needs to be there. Yes, I think it should be torn down and started and begun again. But that's something I think that's so important, is to provide that translation space for people. That's you've already mentioned it before, that has to do with literacy and understanding what's happening to them. It's a huge deal, and I think nurses do get a lot of that responsibility without having appropriate training for it.
And to
That
jump
one
on,
little thing.
go
Oh, sorry. Oh, just one little thing. I don't want to speak for Gabriel, but like I used to lead a HIV clinic. I led a couple of them, and the one thing that does come is like what they say: the squeaky wheel gets the oil. If someone lodges an official complaint, whether it goes to like to the JCO, to the board or whatnot, the medical board, you respond. You respond, especially if it comes to clinical care, and that has always led to a case conference, getting like the case manager together, the clinician, and like often a change of behavior. Like one example, there was one clinician who was saying things that were scientifically untrue, which is something we're dealing with today, who didn't believe, didn't feel comfortable talking about U equals U to his patient pool. And not only was it his patient pool, but because he was fully bilingual, he had a larger percentage of our Hispanic Latinx clientele. So it became a race justice, language justice conversation in addition to a conversation about culturally competent care. But I would never have known that if someone didn't complain, saying that this guy is shaming me and talking to me about condoms, and if I don't use condoms, I'm hurting the Latino community. If that person didn't complain to me, I would have no idea. I didn't want to start this whole process of educating the clinicians.
And I would just add, and building off, I see Dr. David Melbranch in the comments talking about a culture that upholds or holds doctors as infallible. I think one of the things the HIV movement has bequeathed upon the world is a way to not do that. Back in the 80s and 90s and up until today, many people living with HIV, of which I'm one, I've had HIV since 1995, we look at our doctors as consultants who are working for us. And it is an engagement, it's a discussion. It's not top down, it's not a hierarchical thing. Easier said than done, right? I mean, I can say this maybe easier because of my identity. But all of us in HIV, we learned to read, to be prepared, to show up, and to not just take the doctor's answer for the final word. And especially in the earlier days, that was life or death for us. If we had a doctor who was not interested in trying a new pharmaceutical, or who was behind the times on what drugs were being prescribed, it could kill us. So being docile and sitting back was literally a death sentence. So how do we do that? Well, there's lots of great tools to get to kind of bone up on treatments. You can look at things like Positively Aware or thebody.com. You can show up at your appointment with a CDC webpage about what is PEP. We still have doctors who refuse to understand that PEP, post-exposure prophylaxis, is a thing, don't let them get away with it. Say, it is a thing. The CDC says it here. I'll wait while you read it. And finally, you know, power in numbers. So what we did in the early days, and I think it still works, and I recognize that a lot of this is putting the onus on the individual, which is sort of where Lisa was trying to lead us away from. Like, it's not just about the individual has to do all these things. But if you show up with a family member, a partner, a gal pal, someone else who can help make sure that your questions are answered, that you've written down in advance, that you're not rushed out of there, that someone else has your back, it can be easier to advocate for yourself when you've got like some reinforcements, even if they're just quietly giving you strength, sitting next to you. But I think there's a lot of really great lessons from the HIV movement of not holding doctors infallible. We respect doctors, we love doctors, but we will argue back with doctors and we will fight to make sure we're getting what we need, and that we view this as a consultancy. And I think that we can bring that energy beyond the HIV field.
Great, thank you everyone for those comments and that rich discussion. I want to make sure that we are taking some questions that are coming from the audience. And there were two questions that were asked that sort of deal with something that Gabe touched on a little bit around how do we make sort of the spaces where we're providing care or services sort of inviting to the clients and community that we're working with. What are some like just sort of concrete strategies that would get people sort of engaged and sort of make the space more welcoming and accessible?
So first, I want to defer to two people who I will connect anyone happily to. So first, my marketing director, Dave Bridgeforth, who designed the homage library of queer excellence that is our lobby. And just really designed it in a way that looked at subtle elements of educating the community about whatever it is that you do. You know, I mean, I serve on the board of an FQHC, and I know that in their main lobby, they have the history of community health centers, just some cool stuff on the walls. But for cultural spaces and community organizations, I think your art, you know, what you put up, that it speaks directly to the majority of the clients that you serve. That FQHC that I serve on the board for, I think it's like some 20% are Arabic speaking refugees. And so that's a whole population, and you gotta try and speak to that culture of the clinic that has a majority of that demographic. I'll also defer to who is on this webinar, my Director of Behavioral Health, Omar Gonzalez Valentino, who really right now in our new housing development project is playing a very big role about the garden areas, the landscaping, the color of the walls, the color of the pillows, that there are real color wheels and color patterns that are therapeutically more appealing, more appeasing to the senses, the kind of lighting that you use in your facilities. They can often look like clinical county spaces. And I know those are things that one will require monetary investment. So just get that out of the way. It definitely does. But two, it also has a kind of reciprocal effect of increasing your return visits. The clients are more likely to come back and re-engage in other kinds of services, you know, so it's also good business that your client is happy and well and that their environment is comfortable. So, but if anyone wants the information of those two people, they are really the experts.
Any other strategies or suggestions for other panelists?
I'll jump in with our Prep for Love campaign. When we do community mobilization, that's really the lifeblood of the campaign. And that's all about creating spaces that are buy-in for the community. So it's performers from that community, it's artists from that community, it's the food is cooked by people from that community, the bartender, the DJs, everybody is from that community. They're all paid, no one is volunteer. But you work, the communities you're serving, you work directly with them, and they make the decisions about what goes where, how you present things, whether it's in your clinic or an event you're creating. I think you go where the expertise is. And to like Gabriel's point, if you have 20% Arabic speaking folks who are refugees from the Middle East, you speak to them directly and ask them for guidance, and then importantly, follow the guidance.
And one thing is we're moving away, like, so I think when we were talking about the age piece, so the age of the leaders, like, you know, like we like often don't have CEOs. I don't know how Gabriel was when he started his organization, but like we don't often have 20-something-year-old CEOs who are going to set the standard for how we respond to community. And you know, so we know the majority of people living with HIV in the U.S. are people who are over the age of, I think, well, we used to say over 50, but really we're talking about over 45. But then we also know that the majority of individuals who acquire HIV are in their 20s. And so really, like, how are you going to connect with people before they get to their 20s? You don't connect after. How are you going to connect with people like who are teenagers around, you know, are you going to enjoy your sexual reproductive health in a way that's going to lead to ideal health outcomes? So if your communications department doesn't have a TikTok account and a Twitch account, really, what are you doing? So you know, Facebook is for like the 45 and above crowd. Then you have Instagram, who's kind of that leaning group. But like, you know, when you say things like Facebook and Instagram to like younger people, they just look at you like, oh, you poor old person. Oh, we'll smile at you. That's cute. But like, I haven't been on Instagram in like since my mom got an account. So yeah, I'm just on Twitch and TikTok, and I'm sure there's something I don't even know about that's really popular right now. But like, you know, how are you going to stay relevant to the communities that you're serving? So again, how are you going to, like, the things that I used to do? I used to spend at least one afternoon sitting in the waiting area of the clinic and just listen to people. I just like sit there with my little laptop and like, you know, people recognize me, but like, I was like, so they would just tell me things. And then that was how we redesigned our entire lobby, was because of like all the feedback I got. And then like, oh, if you really care about this, do you want to, like, you know, we'll incentivize you to come and give us your ideas, not just, or come sell us your ideas, let's say it that way. I wasn't asking anyone to give their time and energy to something that I was going to utilize that would be more of a business model, because that's not appropriate. We talk about that stuff all the time. But you know, I think that's one of the things you have to do, is just listen to community. And I think everyone said, like, they're not of a particular community that they're serving. So get out of the way. You don't choose people. You're not choosing people who are like-minded to you. Get out of the way and see who comes through the door and listen to them.
Okay, great. So we're going to take a question from the audience. Nicole, we're going to unmute you so you can ask your question about diversifying patient and family advisory councils.
Oh, thank you so much. Yes, I'm a pediatrician and a health advocate, and I've been doing some work with consulting. And one of the things that we're trying to look at is how to diversify the patient and family advisory councils that many hospitals either have or are mandated to have. And I'm curious about the panel's thought regarding how to best do that. I think that there are some true barriers that limit the interest of Black and Brown communities, as well as their, you know, realistic ability to participate. But then, you know, there also is this element of tone deafness among many institutions that they even need to have representation on these advisory councils.
I have a really short answer to that. Make it worth their while. Pay them, give them something they need. Like, there's no reason to ask people to help make us better if we're not willing to provide some incentive for them to do it. That's my answer.
And I was going to say the exact same thing. So right on point, please. The only thing I was going to add is that you assign them a very clear set of authority. You know, I think often people don't like anything that kind of sounds like, you know, BS, like you're just going to hear my advice and it's not going to result in anything. So I would actually identify areas within your institution that you specifically are going to give onto their recommendation. That is and you're clear and upfront about that. And I think that goes into what Cease was saying, is about making it worth their while. It's not just being compensated, because I actually do know a lot of clients who have no interest in getting paid. They would love to just give you their opinion. It's often just, it's inaccessible often. We want it to be in person, or if we do have it digital, we don't take into consideration the digital divide and their inaccessibility to certain tele resources. But, then making it worth their while with both compensation and like actually, prescribed authority that they have.
And what does that feedback loop look like? Like whenever we do these coffee chats or listening sessions or whatnot, at the end of every one, you have to write down, like you have to summarize what was said. And then when you come back a month later, 3 months later, whatever the cycle looks like, you start the meeting of saying how you did or did not respond to each one of those issues. So people have agency and know that their thoughts are like, the number of cabs that I've been a part of are like, oh, we've always just talked into the wind. This is the first time anyone's ever really listened to us. And then that piece of like making sure you're highlighting their efforts. If you have a newsletter, if you have anything, making sure like there are pictures on there, making sure you're very clear on who said what and what contributions they gave, because people really want to know that this time that they're putting in is going somewhere. And like the paying piece, like if you know how much you're paying those consultants who come in to develop this program for you, if you're not paying your participants approximately the same per hour, then that just says where your organization, not your personal. I love you, Nicole, but like where your organizational values are. So like case in point, if you're writing a grant or a proposal, and like you're putting in, when the budget time comes up and you have to put in how much you're going to pay someone who's going to be a part of your program development, and how much someone from academia is going to be a part of your program development, you'll see like massive discrepancies. Like, oh, they're going to get a $25 gift card, but this person coming from academia is going to get $300. Come on.
Yep.
And I'll just jump in, Nicole. Go ahead.
No, I was sorry, Jim. I was just going to say, Dr. Blackstock, there was I wanted to respond to a follow-up comment that was in the chat box around NIH cabs don't precludes members to be paid. So I wanted to say that, I'm actually not familiar with NIH specific grants. And I think just broadly talking about advisory councils, I would say a couple things. One, I have grants that don't allow for the compensation of advisory councils, but it does not preclude advisory council members being compensated. You just can't use it for that funding. If in the event, which I suspect NIH doesn't want any form of conflict, period, so there's no compensation that could take place, I would say that to my earlier point around prescribed authority, like a lot of times people just want to know that like what I'm doing matters. And sometimes when people are paid, that has two effects. It has the effect that one, I'm getting paid. And then two, it's this matters, right? But you can many times supplement people not being compensated if it's the right person who's not in a critical desperation of need, but it's an individual who can, certainly give a volunteer time and they still are a patient and, they're available, making sure that whatever advisory council capacity they're in, that it's one in which they feel as though I am responsible for this. And because I made this decision and made this investment, this then occurred. And so I think making those connections very clear for the community really helps people feel enthusiastic, especially when there is no compensation.
Right on. And I'll just say, I love everything that's been said. Transparency, take good ideas. If any good idea, and implement them. Don't be afraid of someone else's good ideas. They'll make you look good. They'll make the institution look good. There's nothing more annoying than being on a cab or a CAG when you are presented something that the ink is already dry and they just want your rubber stamp. The ink has to be wet or it has barely begun. Like the story starts and in the beginning and then the rest is open. That's when you need to bring people in, engage them from the beginning so they can birth something together, and take good ideas. Don't be afraid of them. I think a lot of us hold on and think, well, if someone else has this idea, I'm no longer relevant or I'm no longer good, so therefore we can't take it. That's the death knell. That's the death knell of getting people engaged. And finally, on the technology front, we've learned a lot during COVID. And you know, a lot of us now are on Zoom. They have never been before. So access to these meetings, if people don't have the tools, give them the tools. That's not direct compensation, but give them the proper device so they can participate in a Zoom call with the team and schedule meetings that fit the lives of the people you're engaging. If you have a CAB meeting that does not really fit the work lives and the personal lives, the family needs of the people who you want to engage, then you're really doing them a disservice. They're just there to be a name on a list. They feel like a name on a list, and they really don't have any impact.
Thank you so much for your very thorough answer to that question. So we're going to ask Gabriel Edwards to come off mute. Gabriel had a question about something that came up a bit in conversation one about medical mistrust and framing it potentially as something that is protective. So Gabriel, can you ask your question?
Sure, thank you very much. Yeah, I just wanted to hear your thoughts on medical mistrust as protective. From my understanding is, you know, like if you frame it as medical mistrust as a product of history of oppression and discrimination, mistrust is a way to actually protect yourself against, you know, against things that hurt you in the past, and kind of how when you frame it that way, what you can do with that frame moving forward when trying to address mistrust in communities.
My short answer is yes. It is a survival technique. Like we can go through the stats, like KFF, Kaiser Family Foundation, released a lot of stats on specific to like the Black African American community, that 70% of Black people report that they don't get the same level of care or been mistreated in healthcare settings. Then like we talk about the current pandemic that's on the news every 5 seconds, like 40% of Black people know someone who has succumbed to coronavirus complications. And, you know, like that's just like one of those strange realities. Like, you know, I work at an organization that has very few white people. And like all of the Black staff, when I say all of the Black staff, I think it's all but one, know multiple people who have died. Like, you know, like 3 in my family, 4 of my personal friends. It's just like, this is like 2020 was just a year of death. And, you know, when you're looking at how are we going to make sure that we overcome this conversation, we have to like look at the reality of what has happened before and like how people are naturally responding. I can use a me example. I get so upset. Both of my parents live in South Georgia. I will fly to South Georgia, put them in a car and drive them to Atlanta, because the data is very true from like just from the anecdotal stories. And you watch the data that the people who are non-white who go into a clinical setting in these parts of Georgia get substandard care. It's not even a conversation of, oh, nuanced anecdotal. The data is overwhelming. And we see this not just in places like where my parents are from, Albany, Georgia, which was the hotspot for the international hotspot for COVID-19 at one point, but more like there's an organization that in New York, Calvin Lord released a study of their own, like a self-study, where they were looking at PrEP offering and testing treat options, and they broke it down by race. And like, you know, Calvin Lord is like the gold standard for culture responsive care for queer trans people of color. And even when they looked at their own data, they saw that the white people were being offered PrEP at a higher rate, and they were being offered testing treat options. Testing treat means that upon having a confirmed HIV diagnosis, you are offered antiretroviral medication immediately, or like within like a couple of days thereafter. And we have found that one of these conversations that happens with clinicians is, oh, well, that person's not ready for it. I don't know, I'm going to let them go home and think about it, And like, so then you're going to have poor health outcomes. And then you come to find out that this didn't happen with the white people. So why would I go back to this clinician who's going to treat me differently than the white people? So it is a survival technique, because like, I don't hate to go through all the medical things that happen in my family, but they're commonplace. It's rare to be in a Black family that does not have multiple horrible stories of what happened in clinical or research settings. So while we're trying to address that directly, we do have to look at like why people are trying to survive in this world, because they want to live. And if you have any value in your own life, you're going to do that risk mitigation, especially if you like love somebody, like your child or your parent, because like, that's why like I will utilize my last resource to go there, pull my parents out of South Georgia and take them up to Emory Clinic or someplace in Atlanta, or fly them or take them all the way to Washington, DC, because I just won't have it anymore. I'm like, without getting too emotional, I'm getting caught up in right now, but it sucks. It sucks, it sucks, it sucks. And so we're just trying to survive and live another day. Thank you, Gabriel.
Thank you, Ace, for sharing that like very personal story. I don't know if any of the other panelists want to add to that. If not, we actually have 3 minutes left, so I would love to use this as an opportunity to wrap up and have our panelists give 1 or 2 final thoughts about the discussion, any advice moving forward as we try to make institutions more trustworthy. Maybe we can start with Cease, if you have any, I don't want to put you on the spot, but or any of the panelists, just any like last minute thoughts that you want to share with the audience.
Sure. I'll be happy to. I just want to echo what Ace said. Personal experiences have really influenced my understanding of medical mistrust. My family has had some awful encounters with healthcare, one almost dying from provider error in a teaching hospital, right? So there's that whole concern about how does that process work? Makes it really hard to trust again. And obviously I tie everything back to my work as a LGBTQ health educator. I've just seen blatant indifference and even resistance to the basic tenets of cultural humility, meaning that healthcare professionals are reluctant to admit their lack of knowledge or to even explore their own implicit biases. So for me, it's, I can't be afraid to call people out. I have the quote from Audre Lorde that says that I have to basically just not listen to fear. I must just, work forward, keep moving forward, and keep working to bring people to a better place. And I'm not particularly hopeful now. I have been more hopeful in the past. I will be hopeful again in the future, but for the time being, we're in a really tough place. But I'm glad this conversation is happening. Thanks for having me.
I'll hop in and make my last comment about medical mistrust. As we all are, I think we're seeing how concerning levels of medical mistrust are right now, in particular with the COVID response, with public health mandates, public health strategies, with the vaccines coming, potential prevention and treatments coming. And Ace is absolutely right. Medical mistrust is a survival mechanism. It's a coping mechanism. It's a way to stay another day on this earth. And I think we have to recognize that and not yell at people when they're freaking out about the vaccine or freaking out about the very mixed messages public health has been giving on masks and distancing and all of that. And I also think it's our responsibility, our collective responsibility, to help people understand when that mechanism for survival and coping isn't serving them. It serves them in certain times, and in other times, it may do a very big disservice to them. For instance, deciding not to take a safe and effective vaccine, and then following what could happen on that. So I think there's a very nuanced place we need to be in dealing with addressing people's medical mistrust as not being about being crazy or anti-vaxxers or whatever, acknowledging that it's real and that it often works and it's important, but sometimes you have to figure out kind of when it's working for you and when you might need to take a different stance. And that's how I'll end. Thank you.
Yeah, my closing thoughts would be that, there are so many tools and best practices and resources and spaces like this. So I don't want to be repetitive in where you can go, right? We know you should know where to go. You can contact folks here. I'm sure everyone has experts that are also within their own local communities as well. But the one thing that we all should do is just be mindful and wary of hypocrisy. That, oftentimes we're doing these things out of a sense of righteousness, out of a sense of good intention, that, somehow we're trying to do better. But along the while, we must always check our own selves, our own privilege. And that term is used a lot, but it really is sincere. And when we say privilege, we're just not talking privilege and identity, but, also how you privilege your ideas, that you really do believe you're right. And I think that we have to check that, because often when we don't, hypocrisy sort of breeds out. And so that would be my only final takeaway thoughts on addressing medical mistrust.
My last piece is this little known product out there. It's called Coca-Cola. So I don't care what part of the US you go to, or really you can probably go to most parts of the planet. Like when I say most, that goes back to that 99%. Someone knows about Coca-Cola. Personally, Coca-Cola doesn't work for me. I don't like fizzy drinks, but I know about it. And at some point I tried it and I kept trying it because everyone else talks about it and they like it. Public health has done a horrible job at marketing and communications, has done a horrible job at addressing like the inequity and awareness and access. But I can tell you just from a model of care of these for-profit places, they know how to do that. They know how to get their message to individuals. They can work on price structures. Like, you're not going to pay the same price for a Coca-Cola at 7-Eleven in downtown New York as you're going to in Biloxi, Mississippi. It's different price structure, but it's still like, even if we are not getting as much return on investment for the same product, we know that sooner or later that's going to help start a movement where we're going to recoup our money. So like, that's the piece. Our money in public health is better health outcomes. And we have to be more like Coca-Cola, get the message out there, make it change. And I promise you, like, you listen to like our friends who maybe work with us who have come from other countries, like the Coca-Colas they had whole different flavors. Like, we just had cherry Coke, and I feel like we got like the short end of the stick on that. They had all these other flavors because it had to be more culturally responsive. It had a different price structure, and like even the names changed. So that's my final piece. Is like, if we're going to address medical mistrust, we need to look at what the problems are, improve our health outcomes by using the best tenets of marketing and communications to show what is actually possible, and not stop talking about what isn't possible. There's a lot of things that are possible if you market it properly. Oh, and thank you again for the invite. You guys are amazing. And all the other panelists, you guys are amazing too.
I think that's a perfect way to wrap things up. And I know we're a little bit over time and members of our audience have to run and members of our panel as well, but I want to just put this back onto you and just say thank you. Wow. From the stories, the insights, the learnings that have come from this conversation, and with the first panel we had last week as well, I want to say specifically, thank you, Ace. Thank you, Jim. Thank you, Cecilia. Thank you, Gabriel. Thank you, Dr. Blackstock. And I want to thank as well Dr. Gomez, who joined us last week, and Sean Demmons as well. And I want to give a special shout out to Shannon Wemmer and Laura Lazar. Without you, this wouldn't have been made possible. So big, big, big thank you. And thank you to my co-founder, Rick Kitagawa, as well, for all his help with this. In follow-up to this, we will be sharing the recordings with everyone who registered, and you should be getting those within the next day or two. And we will also be sharing, we'll edit these down and we will share these with the public as well in the next couple of weeks. So you will find those on the Spotlight Trust YouTube channel. Just search for Spotlight Trust on YouTube, or also on the Trust podcast, which you can find for free on any podcast player. That'll be coming out in the next few weeks as well. So I'll just drop the details here in chat. And this is a crucial conversation. really grateful to have been a part of it this week and last week, but it's one that we need to keep going, and we need you to do that. So one tool to keep us connected is social media, and the hashtag #EndMistrust is one way to do so, but really want to encourage you to keep having this conversation with those around you. It's a really, really important one. And once again, thank you for everyone who's joined us.